I think that our surgical, medical, and nursing support teams are fantastic, and they offer great support for women who are primarily directly under our care or undergoing a treatment phase that involves ovarian cancer surgery. The transfer of care from a point of diagnosis and understanding that primary surgery might not be possible into a primary chemotherapy pathway, or as we call it, neoadjuvant chemotherapy, we can lose touch with women, and then that can become difficult to regain that relationship and that support relationship when women come back into the service for their cancer surgery, which might be midway through their chemotherapy course. One of the things that the pathway would really tighten up on is closing the gap between those two time points where we see people assess them and come up with a management plan, and when we see them back for an assessment of their suitability of surgery if primary surgery was not an option for them. And we'll do that by bringing that assessment date forward, meaning that any pre-optimization steps that we can put in as part of the pathway in the initial phases, the initial assessment, is not so remote when they come back, and so they may have had some benefit from that.
In the surgery phase, when people are inpatients, we generally try and catch up with them whilst they're in. And a lot of that is probably more social chit chat and starting to develop a little bit more of a sort of therapeutic relationship with them and preparing them, or that first stages of adjustment to the diagnosis, because some women won't necessarily know that it's a cancer until the time of surgery. The surgeries, so a lot of adjustment, and then really preparing for sort of the next phase, which would be chemotherapy. So they'll often have a lot of questions about that. In terms of what could be better, it would go back to the prehabilitation, because some of these women are quite unwell when they come in and are often in hospital longer than they could be if they were more able. So I think it's that optimization part and prehabilitation part, which I think would be one of the keys to reducing lengths of stay. The on the ward on 26, 21, wherever they're based, the level of nursing care that they get is exceptional.
Again, we try to see every patient in this Tuesday morning clinic, but we don't. And I know we've got our local CNSs and then they get transferred to us, but sometimes, unfortunately, due to probably current situation as well with COVID, not every patient will see or hear from a CNS, which does bother us. It's, again, I would say probably down to our staffing levels. We don't have the ability to probably ring every patient. What I tend to say is let patients ring me if you've got a problem, or but it's about empowering the patient as well. You don't want them to be reliant on you, because you just want to be part of that journey and you want them to move forward. And currently, we maybe don't have access to everything, but so dates change. Often we miss patients on the ward as well, which is a bit. And it's only happened to us like this week. To be, patient rang us and said, "Oh, I thought I might have seen you," and just put a name to a face, and they bought a surgery forward and we weren't aware of. And and again, I always say to patients, tell the girls on the ward if you need it. So you're empowering the patient, but sometimes you're like.
I think for such a large geographical area, there are ports of call throughout the region for women more locally, in the form of a clinical nurse specialist, for emotional, financial support, and for discussion of the treatment. Good information, but I think it can be quite overwhelming when people get to us. So perhaps earlier on in the pathway, the conversations are kept pretty vague. And I think sometimes when we see women in clinic, it it can be quite overwhelming, all of the information that they get at that point in time, because we're very keen to ensure that people are treated in a very timely manner. I do think the facilities could be better. So I think, you know, when people walk into colposcopy clinic, it doesn't quite reflect the type of treatment that they're going to get. It doesn't reflect what the treatment is like when people come to clinic. And I imagine that might give people some reservations when they first come. I think we work very well with across the different specialties across the hospital. So we've got very good links with radiology, anaesthetics, dietetics, and that's something that we've really built up over the last few years with the help of Chris Ang, who is sort of the brains behind this one-stop approach to this phase of the treatment of women with advanced ovarian cancer. I think women have good access to those services and prompt biopsy to diagnosis, then to treatment. So I think we're doing what we can with what we've got at the moment to be able to improve that side of things. I guess the only downside is we really want to be treating some women with surgery very quickly, and the same with chemotherapy. And we have to work within a system that is pretty overloaded at the moment, particularly with COVID and with the vast number of people across the region. You know, sometimes we're listing people for surgery in 6 weeks at the moment after they come to see us in clinic. And for some women, that might make the difference of being operable or not operable, or well enough for treatment or not well enough for treatment. So whilst we're very proactive, we still aren't quite there with the infrastructure to be able to see someone in clinic and then list them for surgery the following week or the week after that, because we know that time is really precious in order to get women treated appropriately.